Following on from the previous speakers, I intend to raise your awareness and provoke your attention to the thoughts of simulation, evolving subject. As an anesthetist, my thoughts are going to be, or my discussion is going to be heavily weighted towards anesthetic practice. Please bear with me. And I hope I can carry you through this discussion pain-free, but not sedate and amnesic. We have achieved many feats together. One of the feats, the example is that from the humble beginnings in Kaidadi, we have moved on to a beautiful, fully fledged faculty building. And this is not the Rogues Gallery on the left side, it is our dear old university beginnings. JMFA is celebrating its 10th anniversary in Jaffna, where our roots begin. And I'm thankful that we are able to provide some sort of assistance at the moment with basic life support teaching every time we are able to come here. And that is one of my colleagues, Dr. Chapman, on the right-hand side with the fiber optic bronchoscope, doing some training on airway management, and at the same time we managed to do an ultrasound-guided nerve block simulation as well as theatre work. College of Anesthesiologists has been on the forefront of many milestones achieved in the country, the latest being obtaining authorization for European life support certification. Jaffna Anesthetic Department, in collaboration with the college, has always been held in the training programs, training the junior doctors for ALS. And the College of Anesthesiologists also has trained several of us. We are hopefully progressing well in our adapted countries. I hope this is an achievement and not a good riddance, madam. Medical training traditionally was a hands-on bedside teaching and perioperative teaching and formal lectures, workshops, and in a semi-conscious level, we always had a feedback and reflection which was never in the past documented. Now it is documented well and we go through a formalized system. Now, unfortunately, the bedside and the perioperative times are the worst times where adverse events happen. Now, is there a way that we could overcome this? One of the devices with the technological developments that people devised was technology-enhanced learning. It consists of a spectrum of modalities that within which real-life tasks and experiences are recreated for us to acquire knowledge and technical skills, as well as developing good human factors, particularly interprofessional, collaborative team working. There are several modalities. Today I am planning to talk about human patient simulators. The simulation is described as a technique that imitates several scenarios and that helps us in our study and personal training. It has been shown that simulation increases effective learning, promotes memory retention, and ability to build up on our knowledge and skills, that is called constructive training. Simulation is adopted mainly in the airline industries and war zones, where in military and every aspect, engineers simulate their bridges on computerized programs, and they show the strengths and stresses. I intend to share this history, the story of Mrs. Bromley. She's a young woman who came in for a simple ENT procedure, anesthetized by a senior anesthetist with a lot of experience. And She, this is a video that I will describe at the same time as the video goes on. She was induced, as usual, with propofol, and after induction, there was a difficulty in placing the laryngeal mask airway. Therefore, the anesthetic was deepened, and the anesthetist still had difficulty in placing the second LMA. So he has paralyzed her, tried to intubate her. SATs are 73. She is hypoxic. There is persistent attempts at intubation despite the help of another colleague anesthetist and the ENT surgeon being present in the theaters. There was continuous attempts at intubation, maintenance of airway, but nobody had proceeded to talk, communicate, lead the scenario. It was a chaos. It was a glaring example of what not to do. Obviously, this is a reconstructed scenario, not the truthful, but this is what reconstruction brought about. Now, there was glaring examples of absence of situational awareness, absence of planned tasks, communication, leadership skills, and teamwork were all absent. We all have played as youngsters with paper boats. If we are not careful and the paper boats are not guided well, they capsize and we are left devastated. But the paper boats, they don't come back. We can reproduce another paper boat and we can proceed. But for the paper boat, that is end. So we have to be careful about these things. And it's interestingly, there were guidelines pre-existent even before Mrs. Bromley's death. She died of severe cerebral hypoxia, obviously, in the ITU after this unsuccessful event. Now, every time on the Difficult Airway Society guidelines, which was pre-existent before this incident, it is highlighted oxygenation, oxygenation, oxygenation. And there are several different plans at different stages of failures, which could have prevented her death, maintained her oxygen, and there was definitely the surgeon being present could have helped with this. Now, Aristotle identified what we repeatedly do is more important, making it a habit and developing excellence. This is long time ago a Greek philosopher's suggestion. Now, I would like to take you through another organized way of dealing with this issue. This is a simulation, actual simulation scenario. This is an anesthetist who is anesthetizing a mannequin, and after pre-oxygenation, she is going to have a look at the larynx with a laryngoscope, and she fails to be able to find the trachea. Now, everything is being monitored in a simulation control room, including the saturations monitoring and what the anesthetist does. She has called for help, and she has. If you see this, you will find she has called for. She has called for help. She has a plan B, different plans to and maintain the oxygenation all the time, communicating her difficulties to her team members, taking a lead, and distributing the work to others, asking them to call for help and so on, and asking them to bring in all the equipment. Now, we are able to pause this, and if there was anything that went wrong, we go back to the control room, discuss, and see how things can be changed. So there is a safety mechanism in simulation where their patients are not harmed and we are not afraid to do things and learn from it. So one of the advantages of simulation is we can stop, start, and learn from what is happening at the time of the event. The other advantage is we can repeatedly perform simulation at regular intervals, different scenarios, which may be something that is rare events, so that we are able to meet these events carefully and overcome. So it is an interaction between knowledge, skill, and human factors. The human factors are the important factors that we develop in the skills training lab, which is about situational awareness and team working, communication, making decisions, and planning ahead. This is based on patient safety and the learner safety and the benefits that I have already discussed. And part of it is to help competency-based assessment and feedback and quality assurance that we are required to demonstrate. So if I ask in the audience, how many of you have done simulation? Is it possible to show me a show of hands, please, who have done simulation? Yeah. I suspect it is more than that. All of us have had simulation. We have done exams. We have sat in a situation where we have the past papers, time ourselves, and simulate an exam situation. We have all benefited from that. So there is definite evidence that we have become medical students or doctors. That is an evidence that has helped us, that we attempted some form of simulation to perform well. So probably we are all unconsciously doing some form of simulation, but without acknowledging ourselves. There are a lot of drivers, and the evidence nowadays is, although it is difficult to obtain evidence because there need to be large studies, there is definite evidence for simulation for educational effectiveness and complementing the clinical training, and also for developing knowledge, skills which are transferable to real situations. But there is but there is limited evidence for positive effects on patient outcome and safety. Now, let me conclude with, let us make it a dream. We can all achieve what Vasumati had requested about ALS training, basic life support training. I understand that it is small steps that we have to take, but ultimately let us dream to establish and achieve a simulation lab here in the future. Thank you very much.